Hi everyone, welcome to today's Brown Bag in Science at ACSM. We're happy to have Dr. Beth Taylor with us today as our presenter. We're going to start with a few housekeeping items. First of all, if you have trouble hearing today, just log off and then log back on to the webinar. I'll tell you a bit more about Dr. Taylor in just a moment. Today's format will include a 30-minute presentation by Dr. Taylor, followed by some time for questions and answers. If you have questions during the webinar, please type your questions into the question area on the GoToWebinar screen. Here's a little bit about Dr. Taylor. She's an associate professor of kinesiology at University of Connecticut, as well as the director of exercise physiology research at Hartford Hospital. She has previously held research support to investigate the effects of factors such as smoking, testicular cancer, exercise, and aging on vascular function. She also has been a principal or co-investigator on several NIH-funded projects involving the pleiotropic effects of statin therapy in humans. These projects include investigation of the direct effects of statins on skeletal muscle strength and aerobic performance, the effects of coenzyme Q10 supplementation on skeletal muscle side effects, and cognitive side effects of statins assessed with functional magnetic resonance imaging. She has also recently been studying the effect of aerobic exercise training on brain volumes and memory function in individuals at risk of Alzheimer's disease. Beth is an avid runner herself, and she's conducted recent studies at the Boston and Hartford marathons to determine the effects of sustained endurance exercise on blood clot risk, markers of cardiovascular injury and stress, and the effects of cholesterol-lowering drugs on these biomarkers. Beth is also the co-chair of ACSM's Research Review Committee. So we'll say welcome to Beth, and we'll turn the presentation over to her, and then we'll come back in a little bit for some question and answer. Thanks, Beth.
You are so welcome, and thank you so much for having me. So I will have just a little disclaimer that when I talk today about cholesterol-lowering drugs, I was hoping to get time to talk about mind, but I'm probably going to focus more on mortality and muscle because the mind aspect's a whole different segment of this, but feel free to ask questions about that at the end. So I want to start by giving a brief overview of what I'm going to talk about today. And in essence, what I'm going to cover is what do I study? That's statins or cholesterol-lowering drugs. Why is it important? And I'll start with the phrase, no good deed goes unpunished, and tell you exactly what that means as we refer to statins. And then I'll finish by talking about why my research is important within the context of American College of Sports Medicine. And you'll see that there are interactions between statins, skeletal muscle, exercise capacity and tolerance, physical activity, and even metabolic disease. So in essence, you might be saying, well, how doesn't it fit? And there's really no way that statins aren't important. So let's start by defining the term statins. Statins have a long, complicated title. They are hydroxymethylglutarol coenzyme A reductase inhibitors. So what may that be, you may be asking? That is the rate-limiting enzyme in cholesterol synthesis in the liver. And what statins do is reduce the production of the second cascading metabolite in cholesterol, that's mevalonate. So because they are so effective in reducing the cholesterol synthesis, they're the most effective drug for lowering LDL or bad cholesterol in the world, and they're among the most prescribed drugs in the US and the world. I always like a good picture. So if you want to know what a statin does, take a closer look right here. On a regular basis, when you are hanging out and being a normal human, in the liver, cholesterol is being synthesized at a fairly regular rate. This is called the endogenous pathway. Because your liver is so good at producing cholesterol, your LDL receptor synthesis is downregulated. So you don't really need to pull much cholesterol out of the blood. Instead, your body produces almost all of it in the liver. And you can see then you only have one receptor here and a lot of cholesterol in the blood. When you plug a statin into that cog, effectively stopping it, cholesterol synthesis is lowered. Again, that's because you've reduced the rate-limiting enzyme. You'd produce less cholesterol. And now LDL receptor synthesis is upregulated. You make a lot more LDL receptors and they pull that cholesterol out of the blood and your LDL level goes down. So we know that statins are life-saving drugs. One of the reasons they're so powerful is because if you look at the relationship between LDL and event rate, or really anything related to cardiovascular disease, it's a linear relationship. And this is really uncommon in physiology that you see a linear relationship. Think about something like blood pressure. Lower is not always better, it's only better to an extent. But LDL, the lower you go, the better it is for reducing cardiovascular disease. And I could show this graph in a bunch of different ways, but if you look at some of the largest trials out there on statins, you can see that patients on statins almost always fare better than patients on placebo, and this has been duplicated with millions of patients at this point. So put it simply, statins reduce total and cardiovascular disease mortality as well as cardiac events by 20 to 44%. Right now, a quarter of all US adults over the age of 40 use them, and 50% of adults over the age of 75 years. So somewhere between 1 in 4 and 1 in 2. And despite that prevalence rate, there are 25+ million adults in the United States who are not being treated by statins. They are underutilized. And at the cost of about $300 per year, this is a really cheap, powerful way to improve cardiovascular disease survival and reduce mortality. So we really want to increase the number of adults using statins. In fact, statins are considered such a potent tool against cardiovascular disease that you constantly hear discussions like this: should they be like fluoride? Should they be put in the water? Many cardiologists feel that anybody over the age of 40 should be on the statin. Very popular, very potent, very effective. So let's get into that phrase, no good deed goes unpunished. What specifically do I mean? What is the punishment with statins? Well, unfortunately, statins do come with some side effects. And one of the most common is statin-associated muscle symptoms, or what you're going to hear me to refer to as SAMs. This is the most commonly observed side effect in patients, not to be confused with a much less frequent, very rare side effect, rhabdomyolysis, which does occur, but extraordinarily rarely with statins. When I say SAMs, I'm talking about mild muscle complaints, cramping, weakness, aching, and pain. Surprisingly, the true incidence of these are unknown. We suspect that it's somewhere around 1 to 25% of patients experience SAMs. Why it's unknown is because most major clinical trials of statins have not measured them. In fact, there have only been 2 or 3 trials of statins that have ever directly asked patients about muscle complaints. Most clinical trials don't report mild to moderate side effects. They only report major side effects, such as when creatine kinase exceeds a certain level. So SAMs typically go unreported. So why is this important to us as clinicians or to patients? Because unfortunately, SAMs reduce medication compliance. Now, despite all the good things I've told you about statins, they have an abysmally low compliance rate. Over 3 years, the compliance rates can be as low as 33%, meaning that only 1 in 3 patients persist with their statin prescription 3 years later at follow-up. And SAMs accounts for the primary reason why patients using statins discontinue them. And of course, when a patient discontinues their statin, then their risk of cardiovascular disease skyrockets. On average, their healthcare costs increase about $1,000 more per year, and this results in a 25% increase in cardiovascular disease. So there is a real financial, economic, and health risk of not using a statin when you need it. Not only that, even in the patients who continue to take their statin despite having SAMs, they report decreased quality of life and a decrease in physical activity because their skeletal muscles hurt. It's not so fun to do physical activity when you're achy and tired and cramping. And of course, we know that exercise is medicine, especially for cardiovascular disease. So we do not want the primary drug that we use to treat cardiovascular disease to be reducing physical activity. And then finally, from an economic perspective, patients with SAMs do have an approved drug that can be used. It's called a PCSK9 inhibitor, which is a fairly new drug. Unfortunately, PCSK9 inhibitors cost about $8,000 a year versus, remember, a statin prescription is $300 a year. So trying to figure out a solution to SAMs would be a lot cheaper than putting all of patients with SAMs on PCSK9 inhibitors. So You are probably asking at this point, okay, so why don't you solve SAMs? Or if not you particularly, Dr. Taylor, why doesn't anybody solve SAMs? In other words, how bad does it have to be before you actually do something about it? And here are the barriers right now to this problem. First and foremost, SAMs problem number one. Up to 30 to 50% of SAMs may be non-specific, not actually related to the statin. So this is kind of a difficult complex issue, but what we know is that not all SAMs are actually SAMs. There is a strong, what we call nocebo effect with statins, which is the expectation of harm, meaning so many patients have heard about the muscle side effects that they think they're going to get them, and they do. But the truth is, it is all in their mind. It is psychological. We also know that patients using statins are much more likely to have non-specific muscle effects. For example, a patient using statins with cardiovascular disease is often deconditioned. They have other medication interactions. They have certain diseases and conditions which may predispose them to muscle side effects. These are not directly causal to the statin. And then we also know, related to this nocebo effect, that the more negative reports there are in the media about statins, the more likely a patient is to discontinue their statins. So simply starting your statin in a time when statins are getting bad press affects whether you think you have SAMs or not. So a lot of issues with the diagnosis of SAMs. And in fact, to prove that to you, I'm going to show you data from two trials, one that we did, the coenzyme Q10 and statin myopathy trial, and one a larger clinical trial run by Amgen. And what we did in both of those trials was take patients who had self-reported SAMs and then give them a double-blind placebo-controlled crossover. So they either got statin first or placebo first, and then crossed over to the alternative treatment. So we said that they were only truly a SAMs patient if they had muscle complaints on statin. If they had muscle complaints on placebo, or muscle complaints on neither, or muscle complaints on both, then truly their muscle symptoms were not causal to the statin. And if you look at the combined percentages, you can see that out of all those patients, only 43% of the patients who had self-reported SAMs actually had muscle complaints on statin only. 30% of patients, for example, had statin, what they thought were SAMs, when they were actually on placebo. So here then is SAMs problem number two. There are no direct diagnostic tools for SAMs, only patient self-reports of symptoms. That means there is no biomarker for SAMs. There is no clinical test that you can give a patient to say, how do you truly have SAMs? And all of you probably can think to yourself that when you are trying to express or report your symptoms of pain, it is an extremely diffuse symptom. It might be a little bit better than yesterday or a little bit worse than yesterday. Is it totally gone? Did it occur at the same time as the statin? Those are things that are incredibly difficult to monitor when we're talking about a self-reported symptom. And then we have SAMs problem number three. We don't actually know the mechanism of SAMs. So that's right. Many patients who have SAMs appear to not really have SAMs. We have no diagnosis for SAMs, and we also don't know the mechanism. Yet it is the most frequently reported side effect of statins. So you can begin to see the issue. But here is what my laboratory and my work has focused on. We think that there is a solution to SAMs problem number 2 and 3, and this is what we now know about SAMs and physical activity. And I'm going to lead you down the path of some of our research to talk to you about how we think we have both a mechanism and diagnostic strategy derived from SAMs and our understanding of how they work with acute and chronic physical activity. So, a long time ago, with some of the first data on SAMs and muscle symptoms, a couple of studies reported that A, athletes were less likely to tolerate statin therapy than sedentary controls, and B, the percent of people reporting SAMs increased from 11% in inactive adults to 15% in active adults. So this suggests that physically active individuals are less likely to tolerate statins. Why would that be? This is where some of our work starts to come in. This is a 6-month trial we conducted using a high-dose statin, Lipitor, versus placebo in healthy adults. And after 6 months, there was a small subclinical but very real increase in resting creatine kinase, a marker of muscle damage, in patients on atorvastatin, or that's Lipitor, versus patients on placebo. Several years later, when we did that coenzyme Q10 in statin myopathy trial, that double-blind crossover, we saw that that same 20 unit per liter increase in resting CK predicted who did or did not have true SAMs, that's confirmed myalgia versus non-specific muscle pain. So that 20 unit per liter increase in creatine kinase, that subclinical muscle damage, seems to be related to statins and perhaps provide an answer. So that gets us more directly to exercise. Back in 1990, Dr. Paul Thompson, with whom I work at Hartford Hospital, reported that patients on lovastatin had a greater creatine kinase response to downhill walking, this is pre versus post a downhill walking bout, than patients on placebo. Serum creatine kinase is on the y-axis. So what does that mean? Well, you know, downhill walking creates a massive eccentric exercise boost and a lot of muscle damage. That's why we're so sore after we do it. And somehow statin therapy seems to exaggerate regular exercise-associated muscle damage. So now it's not just resting CK that statins appear to elevate, it's exercise-associated CK as well. We proved this again several years later when we did a field study at the 2011 Boston Marathon, looking at 37 statin-using athletes and 43 controls. Those of you who aren't familiar with Boston, it's a downhill marathon. It starts at 490 feet above sea level, ends at 10 feet. So although there's the notorious Newton Hills, Boston is actually a downhill marathon. And so when we went ahead and took CK measurements before, immediately after, and 24 hours after, we saw again, even in patients on a variety of statins, so a less controlled field study, they were on a varieties of statins and doses, even among those patients, sure enough, the statin-using patients had an increase in creatine kinase above the patients not on statins 24 hours after exercise. Take-home message, statins appear to increase both resting as well as exercise-associated muscle damage. And we actually saw a similar trend when we looked not just at creatine kinase, but a microRNA, a small protein fragment in the blood that can indicate other indices of muscle damage. Here's a muscle-specific one, again showing an elevation in that statin-using group relative to the non-statin users. So why would this be? And where did this lead us from this point? Well, there are a lot of potential mechanisms associated with statins and exercise, or the mechanisms of statins and their symptoms on muscle. And they include things like muscle fiber apoptosis, failure to repair muscle damage, reductions in membrane stability, reductions in GTP binding proteins, and importantly, mitochondrial dysfunction. So here is where a statin blocks the production of mevalonic acid or mevalonate. And you can see that when you block this and block cholesterol, you also block some other aspects of the cholesterol production process, specifically coenzyme Q10 or ubiquinone, which is an enzyme in the electron transfer chain of fatty acid oxidative metabolism. Now, we and a bunch of other people along the same time started to show that in patients with reduced mitochondrial function on statins, they also had elevated CK levels due to potentially greater muscle damage. So the picture started coming together a little bit more. And I'm just going to show you some of the other animal data that came out at the same time. If you look at Vmax or mitochondrial oxidative metabolism, an indice of it, in rats that are on placebo versus atorvastatin, and that's right here, at rest and then after an acute bout of exercise, you can see that indeed animals on atorvastatin have lower oxidative metabolism or mitochondrial function than animals not. And this appears to be directly related to a atorvastatin or a statin-associated increase in oxidative stress. Similarly, when you train humans who are on statins versus humans who are not, the entire training response is almost abolished by statin use. So here's the increase in VO2 peak associated with aerobic exercise training. It's nice and robust in the patients that are on placebo. It is not there on patients who are on statin, and this appears to nicely coincide with the expected increase in citrate synthase, an enzyme associated with oxidative metabolism that doesn't occur in patients on statins. So let's put this all together now. Where I said that we think we have a solution to SAM's problems number 2 and 3, the lack of mechanism and the lack of diagnostic tool, we started to say, if the mechanism is mitochondria, then the diagnosis might be NIRS. So let me take a step back and just tell you briefly what NIRS, or near-infrared spectroscopy, is. NIRS takes advantage of the fact that if you send an infrared light source into the skeletal muscle, it will be absorbed at different spectrums by hemoglobin that is carrying oxygen versus deoxygenated hemoglobin. So all you need is a source of light and then something to detect the light that is coming back at you versus the light that has been absorbed, and you can get a sense of how much hemoglobin in the capillaries is either oxygenated or non-oxygenated. And this is a really nice non-invasive way to look at oxygen extraction, which is proportional to mitochondrial function. So for example, if you look right here, this is a period of tissue ischemia in the muscle. You can see that deoxygenated blood increases. Why? Because you're pulling as much oxygen as you can from the blood when you have tissue ischemia and you're no longer getting a regular source of oxygen. And that goes hand in hand right here with the fact that oxygenated hemoglobin is decreasing. Reperfuse the muscle and look what happens. The oxygenated hemoglobin increases dramatically, and the deoxygenated hemoglobin starts to decrease because you no longer need to extract very much oxygen from it if you're nice and perfused. So NIRS can help non-invasively measure oxygen extraction, which is proportional to mitochondrial function. So several years ago, at putting all this together, I gathered pilot data in patients who are on statin therapy versus not on statin therapy, and we looked at their oxygen extraction over increasing levels of hand grip exercise. So the baseline data are in dark blue and the statin data are in turquoise. And you can see that at baseline, when a patient wasn't on a statin, these are just 6 patients, they had a nice robust increase in oxygen extraction across increasing workloads. And that's what you'd expect to see, right? As the demand of exercise increases, the muscle responds, you proportionally pull more oxygen for the working muscle. However, if you look at a patient who's on statin therapy, even if these patients don't have statin-associated muscle symptoms, these were just healthy adults, even in those patients, you have a blunted increase in oxygen extraction with statins. So what we think is that patients on statins have a blunted oxygen extraction, blunted mitochondrial function. This may be the mechanism behind statin-associated muscle symptoms. It may explain some of the statin muscle side effects. And luckily, other people agreed that this was important, and I have an ongoing American Heart Association funded study looking at just this parameter in patients with a self-reported history of SAMs, trying to figure out if NIRS during hand grip exercise could be a diagnostic tool for statin-associated muscle symptoms. If so, if that's the first step, that we finally have a diagnostic tool for SAMs, then we can start to figure out who should be encouraged to stay on statins, who should be encouraged to switch to another drug, and what types of treatments for SAMs are effective. So here are the points of why we care and why this is related to American College of Sports Medicine. Well, the first big issue is if SAMs are increased by exercise and patients with SAMs don't engage in physical activity, then this may reduce overall statin efficacy. So what do I mean like this? We know that there's a great mortality benefit of just exercising. And these are great data from the Cooper Clinic showing that no matter how much exercise you do, and this is exercise parsed against a number of quintiles, whether it be time in minutes per week, distance, frequency, amount, or speed. No matter how much exercise you do, you reduce your cardiovascular mortality by just doing something. There are not necessarily increasing benefits of doing a lot more across these increasing quintiles, but doing something is so much better than doing nothing. It's about a 60% or 50% reduction in your cardiovascular risk. However, when we look at mortality data associated with statins and physical activity, we see something even more important. That is, there is a synergistic effect between aerobic fitness and statin use on mortality. And I just want to show you right here the age-adjusted hazard ratios. If you look at patients, for example, who are highly fit and taking statins versus highly fit and not taking statins, the hazard ratio, the cardiovascular event ratio, is far lower in the highly fit statin users. Same thing within a fitness group, right? These are just fit athletes right now, or fit individuals. Same thing, being fit and taking statins is much better than being fit and not taking statins. So we know that there are synergistic benefits of statins and physical activity. So the side effect of statins on skeletal muscle and impacting or changing physical activity reduces the effectiveness of statins. And we care point number 2, because not only do the mechanisms underlying SAMs reduce the effectiveness of statins, they also may explain the metabolic risk of statins. So a very real side effect of statins is that across increasing levels of fasting blood glucose, there is a slight increased risk of getting diabetes, new onset type 2 diabetes with statin use. And you see it's really exaggerated at the highest levels of resting blood glucose. So for example, in this level of patients who had resting blood glucose of 120 to 125, the risk of sustained type 2 diabetes was greater in the rosuvastatin or the Crestor group versus the placebo group. So one of the mechanisms by which we think statins may increase the risk of metabolic disease is specifically resting around their effect on skeletal muscle and mitochondrial function, perhaps shifting energy metabolism to a more preferentially glucose-based metabolism rather than a fatty acid oxidative metabolism. So putting it all together at this point in time, here's my diagnosis, my schematic of what this issue looks like and what we're trying to study. So I'm talking about SAMs. And what SAMs really are when patients who take a statin have symptoms that seem to occur at the skeletal muscle mitochondrial region. And why is this important? Well, for several reasons. First of all, patients who take SAMs and stop their statin therapy have a far greater risk of coronary artery disease because they're not compliant with their statin. Second of all, patients who take statins and also get SAMs may ultimately have a slightly greater diabetes risk because we think the mechanisms may be related. And third, patients who take statins and have SAMs also have decreases in routine physical activity and have acute effects, what we think may impact them on a regular basis due to their increased resting creatine kinase. The picture gets even muddier because now if a patient with SAMs has decreased physical activity or interactions with exercise, as I said before, their effectiveness of statin therapy may be reduced. And of course, if you're less physically active, then your diabetes and coronary artery disease risk are going to be increased. And of course, if your coronary artery disease risk is increased, then that's going to also impact your physical activity levels. And then diabetes and coronary artery disease themselves are interactive risk equivalents. So taken collectively, then you can see that this is a complicated picture, and at some point in time, starting here with the diagnosis and treatment and mechanisms of SAMs is necessary for us to disrupt all of this ensuing cascade. So the conclusions that they have with these data are that statins are life-saving, cost-effective drugs. They should be more widely used, and their compliance should be encouraged because they are an extremely effective way to reduce cardiovascular disease. However, the most frequent side effect associated with them, SAMs, are extraordinarily hard to diagnose and treat because they're a diffuse symptom with no proven mechanism and no diagnostic biomarker. Since we know that SAMs may be exaggerated by exercise, we speculate that the mechanisms could be related to mitochondrial dysfunction. And although I just showed you a tiny little taste of the literature, there's a lot more out there directly linking these two. Because now we know about that statins may be related to mitochondrial dysfunction, our hope is that using a biomarker like NIRS, as well as some other techniques we're also working on, we can improve the diagnosis and treatment of SAMs, ultimately hoping to change that negative cycle between physical activity and metabolic disease risk. So I'll end right there because I think I've hit my time point almost perfectly, and just acknowledge all my funding sources. There have been a lot of great collaborators on this study, and they're very difficult studies to note. Most importantly is Paul Thompson, the head of cardiology at Hartford Hospital and past president of American College of Sports Medicine, as well as Dr. Linda Pescatello. So I'll take any questions you guys may have.
Great, thank you, Beth. That was really, really interesting. So we do have a few questions. So somebody asked, have there been any studies looking at individuals who are concurrently taking statins and coenzyme Q?
Yes. And in fact, I will refer you to our study because it was, I think, the best study, and I'm not just saying that, done on statins and coenzyme Q10. And why that is the following. There have been, at this point in time, probably about 8 good studies done on statins and coenzyme Q10. And the unfortunate thing about these studies is that they have oftentimes not tried to determine whether someone truly had statin muscle symptoms or not. And so, as I said, the problem is a huge portion of patients who claim they have SAMs actually do not. So in our coenzyme Q10 study, we first made everyone go through this double-blind, placebo-controlled crossover. So we could weed out all of these folks, people who had statin muscle symptoms on placebo, people who had no SAMs, people who had SAMs on both placebo and statin. We took only what we called the true SAMs patients, or the confirmed SAMs patients, and treated them to statin and coenzyme Q10 versus statin or placebo. And when we did that, we found absolutely no effect of coenzyme Q10 on any indice of muscle pain, muscle tolerance to pain, muscle function. And we measured muscle strength, we measured aerobic oxygen uptake, we measured RER, we measured lactate threshold. We looked at every possible way that we could to look at muscle function, and we found no index of CoQ10 on that. We also found that it had no effect on statin muscle pain. And there's been a couple more recent literature reviews and meta-analyses reporting similar findings, that although coenzyme Q10 anecdotally seems to work in some patients, it doesn't hold up, especially in randomized controlled studies.
Thank you. That's interesting. I think that's just anecdotally what we often hear is that people have started using the Q10 and it's supposed to help. So it's helpful to hear what the literature says. We have another question. Do statins affect the body's hormone response to resistance training?
That is an absolutely wonderful question, and one on which there is very little literature. So that exercise training study that I showed by Mikas et al. Was one of the first to show that statins impair the aerobic exercise training response. To the best of my knowledge, there has not been a similar study done with statins and resistance training. And we've long wondered whether statins paired with resistance training, first of all, whether statins would equally impair the muscle response or the anabolic response to exercise training, and B, whether resistance training could actually be a little bit protective against some of the statin-associated muscle symptoms. So unfortunately, I don't have an answer because good studies on this have not been done. And to the best of my knowledge, there's really very little evidence looking in any way at the interactions between statins and resistance training. However, I will say that most of the studies looking at statins and just muscle strength have, although they haven't been trained, it's just been looking at whether statins impact muscle strength. Most of those studies have shown that when you measure muscle strength rigorously and in a controlled fashion with a biodex, isokinetic dynamometer, then you're not going to see impacts on muscle strength.
Great. How about, does SAMs decrease over time for those who exercise regularly?
Again, another great question. We don't know the answer to that, whether physical activity could actually be a treatment for SAMs. The things that we know about physical activity in SAMs is that physically active people, as I said, appear to tolerate statins less well. But in patients with SAMs, there has never been a study in which they have tried to use exercise or physical activity as a remediation for the SAMs or even tracked someone over time. Again, unfortunately, if you look at the majority of statin data, it's all large clinical pharmaceutical trials. So the interest and desire to measure things like resting CK, muscle symptoms, and certainly physical activity is mostly absent because the outcomes in those trials are events and mortality. So we really don't know that if a patient, whether a patient who's physically active who experiences SAMs, whether those SAMs will persist long term or whether they'll abate or whether physical activity changes the experience of SAMs. What we do know is that when most patients experience SAMs, they either down titrate or they go off their statin altogether. They tend not to stay on the statin when they have SAMs.
Great. Okay, so the next question is, some physicians use statins on pre-diabetic patients because lowering circulating fat may improve insulin sensitivity. You seem to be proposing the opposite. Could you comment on that?
Yes, and I certainly don't want to overstate that because the incidence of new onset diabetes with statins is still fairly low. I think it's something like 6 new cases of statins per 100,000 adults, 6 new cases of diabetes per 100,000 adults treated with a statin versus those who haven't. And all that statins appear to do, or what we speculate, is that they simply cause diabetes to occur a few months earlier to what it would have if the patient wasn't on statins. So all of the large studies weighing the costs and benefits of statin therapy still lie heavily in favor of statins, suggesting that the cardiovascular benefit and even the metabolic benefit of reducing circulating LDL far outweighs the small risk of increased onset type 2 diabetes. So in other words, it is still better for any patient to go on a statin and reduce their LDL than it is to not take the statin because they're worried about diabetes risk. But that being said, it is still a small but significant increase in type 2 diabetes risk. And so knowing the mechanism of SAMs and being able to treat them would go a long way towards abating even patients' worries as well as some clinicians' worries that perhaps they are increasing risk of diabetes with statins.
Great. Okay. Are there any connections with statins and cancer risks? Given high cholesterol is a comorbidity of obesity, which increases the risk of certain cancers, is there any sort of connection between statins and cancer risk?
There have been a lot of meta-analyses and a lot of big studies that have attempted to look at this. And to the best of my knowledge, statins themselves, and I may be wrong on this because I'm not going to know the literature as well as someone who studies this, but to the best of my knowledge, the links are not strong between statins themselves directly impacting cancer risk. In fact, if you look at weight loss in patients who take statins, oftentimes they tend to either gain or be weight stable as opposed to patients who don't take statins. And people have speculated that's because a statin prescription takes away the worry of cardiovascular disease and may actually reduce a patient's adherence to lifestyle interventions. So all that aside, there is no doubt that statins disrupt the complicated cardiovascular disease landscape, which does interact with certain cancer risk. So they probably play a role in the greater cancer landscape, but their direct impact on most types of cancers is not well supported, I don't think.
Okay. So the next question is, can you imagine any way that statins would change the neurological recruitment pattern of skeletal muscle?
Yes, and this has been something we've wondered about, right? So myelination of nerves is due to a adequate level of cholesterol. And whether you're talking about the central nervous system or the peripheral nervous system, we have wondered if in certain patients it may be a myelination issue, so that you have a reduced speed at which nerve impulses are conducted. And again, I think I said this at the beginning, I didn't get a chance to go into some of the central nervous system issues of statins, but far less common and far less rigorously supported by data are reports of patients who experience central nervous system symptoms on statins, like fuzziness, memory complaints, what they consider impaired or slowed cognition, even a few cases of dementia-like symptoms. Now, again, many of these studies have been, or these reports have been self-report, and there's a lot of bias in the data. But when we did our functional MRI study of statins and central nervous system function, we did see some altered patterns in terms of the blood oxygen level dependent signal during certain cognitive processing tasks. So you could take this a step further and say that perhaps in the recruitment of muscle fibers, statins either affect the speed of nerve impulse, or they actually affect the central nervous system interaction with musculoskeletal motor recruitment patterns. So there might be something there. And again, that area of study has not been well researched. I'm not really aware of any available data on it.
Great. That sort of leads us to another question that came in that was, I think you've touched on a little bit, but it was, can you comment on how this translates to the brain? Or I might add, for folks who've had cerebrovascular events and have, been suggested statins for prevention, secondary prevention of strokes, I would assume they experience the same things that the cardiovascular patients experience.
Exactly. So again, statins for the prevention of cerebrovascular events, very powerful, because many cerebrovascular events have atherosclerotic origins. And we think, half of cerebrovascular disease at least really has its roots in the atherosclerotic disease process and vascular issues. So statins are tremendously powerful there as well. And in fact, in all of the updated clinical guidelines for cardiovascular disease, the emphasis on statins for preventing stroke has really increased over the years. That being said, there is this small database on patients who have experienced some level of cognitive side effect on statins. So much so that the FDA actually changed the warning labels for statins to say that in certain patients, they may have central nervous system side effects, even though many scientists felt that that was a very precipitate step. And all we can say is that if there is truly a phenotype of a patient who's susceptible to central nervous system effects on statins, it is possibly due to some critical level of cholesterol in the brain, some critical level of metabolites associated in cholesterol production, perhaps, that influence the way a patient experiences these side effects. But very few trials looking at this. Almost all the trials looking at the effect of statins on the brain have either looked at just basic cognitive testing, memory tasks, and not seen anything because the effect sizes are so small, or they've looked at major outcomes like dementia production, Alzheimer's disease, cerebrovascular disease. So most of those big clinical trials say no negative effects of statins on the brain, but there are patients who really report in them. And in those patients, it's just very difficult to know what to say to them.
Okay, here's another one. Is there any way to mitigate the symptoms related to exercise? So by intervals, intensity, mode, etc. Has there been any research to examine that?
No, not whatsoever. And of course, this is a complicated issue because when you are studying repeated bouts of exercise and measuring CK, the skeletal muscle gets acclimated to it, right? So you can't do repeated bouts of muscle damaging exercise and measure CK and have them be equivalent. So it's very hard to do a repeated crossover study where you have exposed the patient to multiple bouts of exercise, measure, say, for example, CK with statin use, and try to look and see if there's different paradigms that might look different. What we do know and have data on is that if you have the lower the vitamin D level you have, the higher your CK response to exercise on statins. We have a very recent downhill walking study in which we looked at varying levels of vitamin D at baseline, and patients who had the lowest vitamin D, so we're talking in the 20 to 30 range nanograms per milliliter, patients who had the smallest but lowest baseline vitamin D had the highest CK response. So the one thing we could speculate, independent of knowing anything about how to manage symptoms or change physical activity patterns, is that supplementing vitamin D, or at least having sufficient levels of vitamin D, might be somewhat protective.
Interesting. That's really interesting, Beth. We're going to have time for one more question. And the question is, are different fiber types affected by statins to different degrees?
Yes, and I'm so glad you asked that question, because that lies in all the background I wasn't able to tell you. But indeed, we do know that type 2 muscle fibers appear preferentially impacted by statins over type 1. So type 2, obviously, your glycolytic fibers, much more impacted, interestingly, than your type 1 fibers. Other kind of interesting facet of this is when you supplement skeletal muscle, when you supplement orally with coenzyme Q10, coenzyme Q10 preferentially increases in type 1 versus type 2 muscle fibers for obvious reasons. So one speculation that we've had about some of these coenzyme Q10 trials is maybe we're just not getting the coenzyme Q10 to the right place. It's the type 1 fibers are taking it, but they're not the ones that impacted as much by statin use. Then perhaps our supplementation studies haven't been effective, and we would really need to get the coenzyme Q10 directly to the type 2 muscle fibers. But regardless, there are good data, especially in animal models, showing that those type 2 muscle fibers appear to be more effective than type 1 muscle fibers.
Great. Thank you so much. This has been great, Beth. I think everyone pretty much knows somebody who's taking a statin, or they at some point in their life have to take a statin. So it's good to get this recent information. We really appreciate your time today. For everyone listening remotely, thanks for your participation today. And with that, here in the national office, we're going to thank Beth, and we'll end our webinar there.